Okay, everybody, welcome to our first DREAM seminar of the semester. It's a great pleasure today to welcome David Camarillo, who's a professor in bioengineering at Stanford. And let me say a few words about David. So David did his undergrad at Princeton, and then he moved to Stanford to mechanical engineering, where he worked on his PhD advised by Ken Salisbury. And at the same time, while he was working on his PhD, he was also working with a couple of companies very interested in medical devices, medical robotics, like Hansen and Intuitive Surgical. And in fact, after he finished his PhD, he went to work for Hansen for a few years, and then decided to come back to academia. He did a postdoc after that at UCSF, and then started his position in bioengineering at Stanford in about 6 years ago. Yeah. So David is, his area of research is designing devices that kind of use mechanics of physics to probe tissues and to probe cells. And so he's got a kind of core set of components in his lab, which are design devices, physics, force probing, etc. And then he uses these for these wonderful applications in the medical school at Stanford. So a few years ago, he had, and I think it's probably one of your highly cited papers, but it's with the fertility clinic at Stanford, where his group was looking at which eggs are more likely to be fertilized or to turn into viable embryos. And this was a paper that came out. And I remember at that time actually seeing some of the publicity about this, because basically they said, you can, based on the study that they were doing, they were looking at the probability of just looking at the egg alone and looking at its force, like the tension or the hardness of the egg. Could you test ahead of time whether that, once fertilized, would turn into a viable embryo, which, as you can imagine, has huge practical consequences. So, but that's just one of his set of projects. He also works, and I guess today you're going to talk about the cardiothoracic work. He also works on traumatic head injuries as well. And he's a winner of a number of awards, a fellowship for that fertility work. You don't even list some of your awards on your website, which I was, why he doesn't list that? So best paper at ICRA, maybe last year or the year before. So welcome, David. It's a pleasure that you're here.
Thank you, Claire. I think I may have broken the lapel mic, so this gets recorded properly. I don't get in trouble. I'll use this microphone. Thanks. It's an honor to be here. I've had a great set of conversations today. I apologize for not being able to shake anybody's hand because family's been sick with the flu. I'm getting kind of progressively worse over the day, so I don't expect to keep you for a long seminar this evening. Part of the reason I'm excited to be here, other than just to share my research and what we've done, is hoping to, through the series of discussions today and through the talk tonight, to engage you a little bit. Present research that some of it that's already published, but I also wanted to tell you about some of kind of the latest stuff that we're doing, where we're getting into some uncharted territory and always open for ideas, suggestions, collaboration, that kind of thing. So as Claire mentioned, we do work in a couple of different areas. I'll touch on that in a minute. Today's focus of the talk is going to be our work in continuum robotics, and that word I think was coined long before the soft robotics was coined. And so essentially what this means, for those who aren't familiar, is these are robotic manipulators that don't have discrete joints. They bend kind of in a continuum. And as you can imagine, that creates some difficulties as far as modeling and control. And so we've spent a lot of time, in fact, in my PhD and as well in my own laboratory at Stanford, on looking at how to improve the dexterity of the manipulation of these continuum devices. They have obvious medical applications here. This is some kind of an endoscope here. And then what I'm going to touch on at the end is the most recent stuff that as we have improved and refined the dexterity and the manipulation of these devices, One of my goals, and I'll tell you why in a few minutes, is really to move these type of devices towards surgical automation. I think there's a real potential benefit there, but we're realizing that one of the bottlenecks, it's of course not just your ability to have dexterous manipulation, it's your ability to localize within the body, which is a moving, dynamic, deformable environment. And I'm realizing there's a lot of challenges there. So I'll tell you our rough initial cut of what we're trying to do, and I'd love to give thoughts. So brief overview of the lab, although Claire probably got this mostly out of the way for me. I'll just show you a few graphics. We do what we call smart biomedical devices. So there's some kind of computation or intelligence at the core. Most all of our projects involve some kind of measurement, very simplistic learning, not as sophisticated as what you guys do. And the manipulation of force is really at the core of it. So the work I'm going to tell you about today is our work in cardiopulmonary, where we have surgical instruments that we're manipulating in contact with tissue. Claire also mentioned the work we do in the reproductive space. We essentially apply forces on eggs, embryos, and try to use that for diagnostic purposes. We also have not yet published, but we're working on doing robotic control and automation of egg and embryo handling. I think there's some interesting applications there if you can gently and precisely control and manipulate embryos and eggs. And then the last area that we have a significant chunk of my research portfolio is in traumatic brain injury. So there's a couple devices that we've built there. I apologize, it's not on this graphic, but we built an instrument, a mouth guard that has sensors inside of it, essentially inertial measurement units, and can take measurements of the accelerations that happen to the head. And our latest, again, unpublished work is we're looking at developing smart materials that can, in an optimal way, absorb energy to try to reduce the likelihood for trauma. So again, that's, as I view it, kind of a manipulation problem. Okay, so to get into the topic today of surgery. So there was a day in which surgeons got to, well, this still happens to some extent today, but much less, got to use their actual hands to manipulate the tissue. And from their perspective, this was great, a lot of dexterity manipulation. From the perspective of the patient, going home with an open wound like this, pain recovery, and of course, risk of infection, there's some obvious downsides. So the next step was minimally invasive surgery. And the idea here, of course, is that instead of one big incision, you make a couple of small ports and you stick through these so-called chopstick devices to perform the surgery, as many of you are familiar with. And there are a number of challenges that come along with these devices. They're, in terms of visualization and control is one issue. I'm going to focus a little more on the dexterity issue today. So most of these instruments do not have a wrist, for example. So you have kind of a pivot fulcrum point that you're steering the device around, and all you can essentially do is grasp. And so that limitation of dexterity means you have to be very wise about where you place your port locations, and you also there's a heavy learning curve in how you use these devices. So that's kind of slowed down and made the adoption of minimally invasive surgery not as quick as it otherwise would have been. Cardiac in particular, there are still open chest procedures. I'm going to talk today about a procedure for cardiac ablation, and that used to be done open, and nowadays this is done through minimally invasive port. This is, I would argue, from dexterity manipulation, even more challenging. This is the patient's thigh. So you essentially thread this little catheter device in the thigh. It goes all the way up the vasculature, then into the heart, and you've got this long noodly looking thing that you steer on the outside. These are 3 degree of freedom devices. So the doc has his or her hand on a little knob. That knob, as you depress it, causes an articulation, and you can turn your hand, and that twists it around, and then you can push it in and out. So you get three-dimensional control, and the goal there is to take the tip of that catheter and steer it around to specific points within the heart. And you can imagine there's a challenge there. It's not so easy to do. So this limitation dexterity was addressed in part, at least for laparoscopic surgery, by Intuitive, and you all know this story. As Claire mentioned, Ken Salisbury was my PhD advisor, and one of the things that came out of his lab when he was at MIT before he came to Stanford was the wrist. So, in addition to all the computer control that makes this more intuitive, it also is more dexterous. So you can have a wrist that gives you more degrees of freedom for manipulating the tissue. And I would argue that there's still some question about, prostate surgery has been the big one for the Da Vinci, and there's still questions about, did it improve patient outcomes? Well, you can argue one way or the other. The thing you can't argue about is it has taken over laparoscopic and open surgery. So those have dropped off precipitously, and the Da Vinci has increased. One reason for that, I would argue, is an access issue. So, dealing with this chopstick surgery was hard to do well, especially procedures like the prostate that required a lot of precision. So when you have a device like this that is easier to use once you're trained on it, you could see that there might be a larger pool of surgeons who feel comfortable doing this approach. There are other reasons why this has taken off, but I think access is one of the issues in ease of use. So in my my own work, I spent a short amount of time actually working for Intuitive Surgical. I also worked for a spinout called Hansen Medical, which is the same founder of Intuitive, and it was a similar idea of take that kind of dexterity enhancement that was provided for laparoscopic instruments and use actually quite different approach, but to improve the manipulation dexterity of Continuum devices. So this is an intracardiac catheter, and again, the goal is to reach different points inside of the heart and create ablations. And so if you're treating an arrhythmia, there's electrical conduction in pathways where essentially there should be no conduction. So when you ablate, you create kind of a high impedance lesion, and it should stop the arrhythmia. But as you can imagine, this is a challenge, and I'm going to tell you about some of the work that I did briefly and that my students have done to try to improve and increase this dexterity in the cardiac space. The other space that I'll talk about today that we've started working in more recently is in lung. So cardiac in some ways is unusual. It's one of the few parts of inside your body where there's a big open chamber and volume, right? The chambers of the heart are open volumes other than the fluid that's in them. Most parts of the body are very much constrained, and the lung is one example. There's some space in the airways, but the deeper and deeper you get out into the branching structure, the more narrow and the more constrained. So for example, you can imagine if you had a lung cancer nodule that was found in imaging at this point, there's a pretty constrained navigation to reach that point. And there are some challenges that we faced along the way that we're still actively working on trying to improve that procedure. So again, I'm going to tell you a little bit about work we've done in dexterity for improving the manipulation of these devices, but I want to foreshadow a little bit the other big challenge, which is this localization. So you can imagine if this preoperative map you have of the lung is static and you want to reach a point out here, it's fairly straightforward. You set some waypoints and you follow the trajectory. This video is meant to simulate breathing, and it's just showing a displacement in the map. But of course, breathing is a lot more complicated than that. You have twisting motion, you have deformation as the device is moving in. So your map does not remain static. It's something that's continuously deforming, and that's a challenge. The way we're trying to approach this problem, just to kind of again give you a heads up, I will get to this at the end of the talk, is to use one of the other sensors. So this has a position sensor in it, but it also has a camera, and the camera stays referenced to the anatomy of interest. So I'll show you a brief video of this. So this is a camera inside of a breathing lung. Let's see, is that working? No. I'm having a little bit of trouble with this video. So you might have to trust me on this one. But what you can see in this video is there's bubbles as you breathe, and the bubbles come in and out as you respirate. So you can definitely see there's breathing, but there's no relative motion of the camera inside the airway. So the camera stays fixed with respect to the airway. What that means essentially is the bronchoscope breathes with your lung. So if you can look at the camera as your sensor, that is reference to the anatomy of interest. And if we can start to use that for feedback, perhaps we can work towards this goal of automation. Yes. Yes. Yeah, so one way that you can imagine this, or at least a portion of this particular procedure that could be automated. So if you Yeah, so what my goal, or kind of a near term goal, we'll see how near it is to, in the branches of the lungs, a doctor would say, we want to get to that spot. That's where the lesion is. And you press go, and the device navigates there. Well, I don't know, maybe. I'd like for that not to be the case. You'll see why in this next slide. Um, so part of the motivation behind automation, there's the normal type of stuff with cars where it's safer, takes the burden off of the driver. But there's another argument, which is improving access to healthcare. So in the world, U.S. to China, across the world, lung cancer is the #1 killer. And if you look at China and the U.S. as kind of a case study, the number of smokers in the U.S. is this little small chunk, and China has many, many more smokers. So there's an impending crisis where they're going to have now people can afford to smoke. They're going to have lots and lots of lung cancer. The flip side of that is they don't have enough healthcare. So we have more physicians per capita than they do. And again, these procedures, whether it be a cardiac ablation or the bronchoscopy, require a physician now, and they require a lot of training. So my hope is that working towards automation in medicine helps export our technology, that we can export things, that we don't have to have people who are experts on the ground that are go through these years and years of training, the cost associated with it. We may not be able to do the whole procedure right off the bat, but I think there are some simple procedures within the kind of continuum medical devices that might be automated. Okay, so before I get into the technical portion of the talk, I just want to give a rough outline. I'm going to start with telling you about some of the work we've done in Dexterity and these continuum manipulators. The first chunk of work that I did in my own PhD was an open loop mechanics model of describing how the continuum mechanics of these devices work. A student who graduated from my lab recently took this a bit further and said, this model is causing us a lot of problems when we're running into things in the environment. So can we just learn in a very simple sense how this device is behaving and have estimation without a model? I'll get into that on the next slide. Yeah, there's a number of them. I've got actually a laundry list of them. So the model list, so that was essentially really throwing out the model and only using very, very simple mapping between the actuators and the displacement. We've realized that there are certainly at least a subset of situations in where retaining some aspects of the model can, in fact, improve robustness while learning from some of the data. So this is some work that Jake Skenga is doing in my group on estimating orientation based on a sensor and using the model. And then the last thing I'm going to touch on is our kind of latest unpublished work in progress, and this is very preliminary stage on localizing in bronchoscopy using a deep learning with real-time registration of a rendered view from a CT and a real camera view to try to figure out where you are inside the lung. Okay, so let me get to your question about what are the problems with the mechanics models. So one of the major problems is we don't model the environment at all. When I came in and started working on this problem, the way that people thought about these continuum manipulators was just in terms of the kinematics. So if you would displace a tendon, these are tendon-driven devices that we've been playing with in modeling. When you displace a tendon, you assume there's a neutral axis that runs down the middle of the device. So you have compression on this side, tension on this side, and you can map out just through geometry and kinematics where the tip would be as a function of the displacement of the tendon. What I realized, which wasn't a major discovery but made a big difference, is that all of this is a deformable body. So even the tendon itself, if you apply enough force on it, it can stretch substantially and you may not reach your target. So there's a stiffness associated with that. Of course, there's a bending stiffness to articulate the device. And the catheter itself has some flexibility to it, and it can compress. And so you have to factor all of these things in together if you want to get a reasonably precise control. And there are a number of assumptions built into this model, and you'll see that these kind of can break down in various situations. So first is no friction. You can do a lot of work in the manufacturing to try to ensure that. Another is there's no manufacturing variability, so so you don't have to try to identify the properties of every device that comes off the line. It can be very expensive to do this, and so there's some reasons why that's a problem. And the environmental contact, that's the other big thing. So when you're working within the chamber of the heart, maybe it's okay. But as you start, even contacting the tip, contacting the body, going in more confined anatomy, that starts to break down. So a couple examples of where that can happen. So these are two manipulators with the exact same identical tendon displacement. So you just pull the right tendon. If you are in open space, this is what the Jacobian would look like. In fact, this configuration at 90 degrees is singularity. So if you pull the right tendon, which is in green, it would move down. The left tendon in red, it would move up. The problem is this has an insert axis as well, and the insert axis is lined up with the left. So you're kind of stuck here. You no longer can move right and left. Now, again, given the same exact tendon displacements, if you happen to be wrapped around an object and you insert, it actually doesn't go straight up. It goes up and to the right. So there's actually a benefit of the contact here, and you can still move out in this direction. So that's one kind of class of problems where ignoring the environment can really mess you up is artificial singularities. Another classic kind of canonical example, so again, same tendon displacements, no contact. So again, there's this insertion axis, which is the red. In this configuration, when you insert in the red, the whole device moves up. But if you're stuck in a channel like this and you're banking off the top of the channel, when you insert the device and push up, the tip actually comes down. So it's going the exact opposite direction. So you can see how that would cause some significant stability problems. You've got a sign flipped. And so again, when you're working in these more confined environments, the no contact assumptions into the model-based control don't work very well. So there are catheters on the market. In fact, we have a project where we're collaborating with Abbott that have sensors in them. And so we can start to learn a little bit about the environment. This particular device has two sensors. It has a sensor, a force sensor in the tip that gives a force vector. It also has a position sensor in the tip that gives a Cartesian coordinate. And so the question then is, can we use that sensor information as feedback to know a little bit more about what's happening inside of the environment and to compensate? Okay, so that was essentially what Michael Yip worked on during his PhD in my lab. And this is a very, very simple notion of learning, which is forget about the model altogether, and let's simply try to build a linear mapping between the displacements of the motors and the displacement at the tip. And what you can do with that is close a control loop that's an inverse Jacobian controller. And you essentially can take the elements of the Jacobian and learn those as you move through space. So as you start to run into objects and it warps your Jacobian, as I showed you in that last example, you can simply learn what's happening by observing the sensor displacements as well as your encoder motions. So that was the rough idea, and I'll show you what this actually does on. This isn't a medical test bed. This is just kind of a simpler setup that we had at the time, where we're actually using the camera for the position sensor here. There's tension sensors. That's another important component to know that you've got tension on your wires and you're not driving slack into them. But this is what the benchtop setup looks like. So let's see if I can run this. Okay, so this device is essentially navigating a path that we've given it. It's these dotted lines through these two obstacles. And certainly, if you're relying on a model of a single curvature continuum trajectory, that won't work at all. So what we're doing here is we're plotting in the same space what the Jacobian would look like if it were just based on the displacements. And what you see is when you go through this middle section between the two obstacles, again, you run into the singularity where the device thinks that the insert, the red, is lining up with the left and right pull wires. But in fact, as you insert, it's pushing you through the anatomy in the direction that you want to go. So this is essentially something that, with this body contact really wouldn't be possible without having some either a priori information or sensed information from the device. No, So the only sensing here is the tip and the displacements or the encoders. Yes. Yes, and it doesn't even really have a notion of where the obstacle is. It just knows what the net effect of the obstacle is on the tip. So it's essentially just learning as it goes. Now, this this way of learning works reasonably well for contact along the body. Where it starts to break down is when you have some significant impedance running into the tip of your device. Because in that case, you very well may be articulating one of your pull wires, for example, into a surface, and your Jacobian would look, it would be very nonlinear. You can't move in one direction, but you can move away freely in the other direction. So it kind of breaks down in the case of. No, there's no right. So yeah, so we hadn't really fused these yet. I mean, my PhD work was about the elasticity, modeling that. My student said, forget that. Let's try to just learn what's happening, and then you'll see next we've gone to something that's a little bit in between. So in the cardiac space, again, the goal was to bring the tip, which is an electrode, into contact with the heart and have an ablation. And so, as I'm saying, when you run into the tip into tissue, that Jacobian that assumes you're kind of in free space really breaks down. So this was another piece of work by Michael Yep from my group that used a force sensor to do a couple of things. So when you come into contact, that happens for you, the force sensor, and so you can do kind of a hybrid force position control. So now, and it turns out that for treating these arrhythmias, the contact force is quite important. You want to get a depth of a lesion that is just enough, but not too much. It can be dangerous if you burn all the way through the tissue. If you don't get deep enough, you may not cure. So you want to control the temperature, the pressure, and the time. So having the force sensor enables you to control the force here at the tip. And then the other little trick is that you use that force sensor to estimate the normal on the contact. And that way you do not estimate the Jacobian in that direction because the Jacobian is no longer linear there. So we only estimate the Jacobian essentially parallel to that plane. So here's a video of what this looks like. So there's and by the way, this is switching back to a medical catheter. So there's a force sensor here. This is the, just as a reference, this is the force we're applying. So we're attempting to apply a constant force dragging around on this surface while following this laser pointer. I mean, the laser pointer, there's a sensor on the laser pointer, so that's how we know where it is. So essentially you can do this kind of dragging motion while keeping a continuous force and learning in the plane of the surface and simply regulating the force into the surface. Yes. No. Yeah, everything. Well, okay, so that's not entirely true. There is an initialization process, but it's very simple. You essentially just do a little wiggle before you start. So you exercise all of the actuators independently. There's your initial Jacobian. And then once you get into contact, we reshape the Jacobian so we don't update it anymore in the plane. But it is still learning. The Jacobian is it. So no, it's just really the elements in the Jacobian is all that we're learning. We're learning, which is the mapping of where the. Yeah, but we're not really building up any representation, and perhaps we should be, but there's no representation of the environment. It's almost like a closed eyes type learning where you're just looking at how the actuators move and what is the response of the tip. Yeah, so, we're not mapping the environment. There's not really a representation. Yeah, perhaps we should be. From the displacements of the tendons to the Cartesian tip position. Yep.
And so if it's gone through a particular area and you're gonna sort of come back, like maybe it's exploratory or something,
There's no memory. No. So that's a limitation as well. So that is to some extent solved by this next approach that we tried, which so if the environment is very highly constrained, this modelless approach can break down. So let me show you an example that starts to look a little bit more like lung. So if you assume you had a tight airway that's going to force you to make a right turn, and all you do to get through this airway is you just push up. You don't actuate your tendons in either direction. So you start out with a workspace that's as such. You can kind of reach 90 degrees to the right, reach 90 degrees to the left, and you can insert forward. Now, if you then, all you do is push. You just insert this thing. You don't actuate the tendons. You can't learn if you don't actuate the tendons. That's the way this learning works. Then essentially it will think that the Jacobian essentially hasn't changed. So the right green stays where it is, the left blue stays where it is. Because we were doing some actuation on the insert, that starts to move to the right. And again, it looks like a singularity. But in fact, that's not the case. You still have the same workspace that you did before. It's just rotated. So you can still move down, move up, and move forward. So this issue in these highly constrained environment motivated us to do a little bit more of a combination between kind of a simple model with some simple learning as well. The idea is that and again, this is in a medical context, we have a relatively short articulating section. We assume now that the bending of this section can be known just by the displacements of the tendon, just of this small section. Now there's, a meter of device or a half meter of device behind it that may be difficult to know or to estimate. And so the idea here is that if we have a sensor on the tip, so this tells you the Cartesian position, orientation in this case as well, and you know the tendon displacements, then you can figure out this relative rotation, and that allows you to then kind of globally figure out where your device is in space. Now, this is very simple to do if you have a 6-dimensional sensor, and if you have electromagnetic sensor, which the bronchoscope that we're working with does. All you're doing is essentially a rotation matrix from here back to here. On the cardiac, we only have a XYZ, a 3DOF sensor. So that's a little bit more complicated. We can't immediately go from XYZ tip position to where the base of the articulating section is. So what we've done in this case is we look at the delta X's, and we use an unscented Kalman filter to try to estimate what the rotation matrix is between the tip and the base. And so those are the two different approaches that we tried here. So the control scheme here, again, is very simple. The key difference from the modelless is the Jacobian here. Again, the Jacobian from the tendons to the tip position it's using a model. Okay, at this time that's using a model. We're not manipulating the different elements. All we're doing is applying a pre-rotation, right? Assuming that, again, if you have an articulating section, the whole thing could be bent one way or the other. We may not know about that. We use the sensor to try to figure that information out, and the tendons to figure out the last component of the articulation. So how does this work in practice? Okay, so we have a few waypoints here that we're trying to follow, and it goes from, let's see, from this one to that one to this one. If you simply use the kind of mechanics model based approach that I first told you about, it would think you just need to go up and turn over to the right. But if you follow these waypoints and you start to run into these obstacles, of course you learn as you're going that you need to in fact move back to the left. So that was kind of a contrived setup. This is more anatomically based as a lung model, and I'll show you what the data looks like in a lung model for these three different approaches: using the model, the modelless, and the kind of hybrid model. So this is using just the model, and we're trying to reach this goal point. So the problem you run into here is the model thinks that you need to go straight and bend to the left. So it starts bending to the left, and it shoots down the wrong airway.
So the goal point is the red?
The red, yes. There's one waypoint. Yeah. So it's this one, then this one. There's essentially two waypoints, I guess. Sorry? Yes. Yeah. So that's coming next. That's what we're realizing we have to make use of, because in this, all we're using here is the electromagnetic sensor in the tip. We're not using the camera information. So it has, 6 degree of freedom, the position and orientation. Okay, so that's what the model base does. So the model-less control, what happens here, it is that it gets stuck. So it's so narrowly confined, it starts to run into the wall a little bit, and it thinks that it needs to continue pulling the right tendon, quite hard, because it's essentially being scaled down to get to the right, and it just gets stuck in the tissue. So it essentially fails. And again, this where we're using just the orientation part of the model, it doesn't scale any of the elements of the Jacobian. It doesn't, think you need to pull too hard or too light. It always keeps that scaling fixed, and so it doesn't get stuck in the same way that the model-less control does. And again, I mentioned there were two ways that we have doing this. One, assuming you have a 6-DOF sensor, another assuming you have a 3-DOF sensor, and they both reach the goal point here. Okay, so to your point, we're not being wise here. We're using this, that sensor, electromagnetic sensor, is mounted to the bed, so it's not even on the patient. And I think you can assume maybe the patient doesn't move their whole body, but certainly in the lung procedure, they're breathing, the lung is twisting, it's contorting, and the camera could potentially serve as a much better reference point if we can figure out how to make sense of what's in the camera image. So this is what we're just starting to work on now, and it's very preliminary work. In fact, I don't even have any experimental results to show you. I just have simulation. By way of background, I should mention kind of what's been done in the field up to this point. In my mind, the most impressive work, and by the way, there have been people that have been working on localization of the lung, not just for robotics, but even just to help the doctor, because if you get deep enough into these branches, you kind of get lost as to where you are. Did I make a left or a right, or was that 2 rights and 3 lefts? So simply rendering in a CT where you are in the lung can be helpful for the doctor, and it's critical for a robot, of course. So what this group did from Penn State is they essentially created this virtual view. So they rendered what a camera might look like inside the lung, and then they compared that against what the actual camera image looked like. In order, their contribution here was to make this fast. So this ran it faster than 30 frames per second, which is kind of the video refresh rate, the requirement, I would say. And the way they did that is instead of doing lots of renderings, they essentially did kind of pixel mappings between a bunch of neighboring images and looked at the deltas between those. So they were just looking at these pixel mappings as opposed to re-rendering. And so they were able to do it pretty quickly. The accuracy was not high enough to get to all of the lung. So this is the position area they reported from their paper. And so this first chunk of the lung that's outlined here, this is where all the airways are about 5 millimeters or more. And so their air, they would get up to around 5 millimeters. So you could argue that they'd be able to localize within that part of the airway. But the only about half of lung cancers are in that little volume there. And if you want to get to 90 some odd % of lung cancers, you need to get your resolution down to just a couple millimeters. So that's what our goal has been, is to kind of take some of these ideas that they put forth and see if we can improve the accuracy so that we can navigate deeper. So this is the kind of approach that we're proposing that we've been experimenting with in simulation. Same idea where you start off with a real image that was snapshot. You are inside the CT. You have an estimated position. You render what that would look like. And then you take the two of these and you feed them into a neural net. And what comes out on the backside, and perhaps we're being a little too ambitious here, we shall see, is we're trying to get a full 6-dimensional relationship between these two images. And then once you determine what that 6-dimensional offset is, hopefully it's pretty small, and you iterate. And so you move your virtual rendering to your last position. And of course, if I flip back and forth here, what it's doing is it's taking two images and it's outputting. Well, yes, except for one of they're different domains. And I think this is where the challenge is. One of the images from the lung came from a camera. The other image from the lung came from inside the preoperative CT, right? So this is just rendered to make it look like it's inside of a lung, right? But in fact, it's not.
So when you train this, you get examples using a synthetic data set for the both virtual.
Right.
And no boundary of the transformation.
Right.
You have a lot of cases of that.
Yep.
Okay. So I believe that works. I think that the interesting thing is now when you now switch over to real,
Yep.
you have very different, there's a lot of artifacts on that.
Yes. Yep.
Although maybe there's a way to learn the mapping from the real back to the virtual, so you can, in other words, adjust the virtual image
Mm-hmm.
more like the real.
Right.
And so that you can adjust the color tone and things like that.
Right. Yeah, I imagine that's where this is going to get stuck. I mean, we just got our first kind of full real data set within the last week, so we're going to test this out right now. But certainly they do look different, and we want to find some domain that looks, I don't know which one we're going to want to adapt, but you want to adapt one or the other so they can look similar. And not exactly sure how to do that, but this is what we're trying. So the way that we're doing the training on this, just to get into a little bit more detail. So this is what it looks like going down the center line of the lung to, let's say this is the goal point that you want to reach. That's what it looks like going down the center line. And so all that we do to train this thing is to generate a bunch of noise, a bunch of perturbations. That's the wrong video. Oh, here we go. A bunch of perturbations. So you could be anywhere, or, some envelope around this center line, and then we take pairs of images in that envelope, and we essentially, in this virtual space, we know the 6-dimensional transformations, and we use that for training. And so what we've done so far, and again, this is very early, is to try to introduce some noise that might be the types of variations we would see in the real world. So we're adjusting lighting, we're playing with the smoothness of the surface, we're introducing random artifacts. And perhaps it shouldn't be surprised that when you test all this stuff out in simulation, you get a pretty reasonable error. So we expect for the size of the airways essentially to never have two images that are too far apart. And again, I said our goal is to get down within a couple of millimeters. Of course, this is cheating because we're training. Yes, between two images, exactly. Yeah, but I think Ken is right. The real challenge is these aren't going to be. They're not going to look exactly that. They're going to look different, right? And especially when you have sort of bubbles that are bubbling up and speckle and so this might be quite challenging. And of course, there's we're asking a lot. We're trying to get a 6-dimensional transformation out of just two pair of two images. There might be other approaches that we could take where we're trying to get simpler. Right. Yes. Yep. So when you get to a bifurcation, there are some nice features. One problem is that you get saturation with the light source a lot. So a feature could drop out at any moment if you shine your light out in the wrong way. The other issue is when you're moving through an airway before you've reached a bifurcation, everything looks the same. You're just going through a tube, right? Right. That's a good idea. Yeah. The other thing we were thinking about recently, because these data sets we have are all from humans driving through, if you're going to have a robot do it autonomously, why not just scan the thing around and try to get a lot more. I mean, sometimes you'll come up at a trifurcation, for example, but you're looking in a way such that you only see two of them, and you could pause, you could get fooled. So I like that idea. If you vary the light source in addition to scan around. Yeah.
So, given your experience in this area of research, if you or your family ever were to get lung cancer, would you just not undergo any treatment, or would you, given that these things are so inaccurate?
Okay, so I didn't say much about the clinical problem. So the clinical problem is the false negative rate is high. So what that means is they see something on the CT, you go in to get a biopsy, and you bring the sample back, and it just looks like regular cells, right? So you don't really know. You essentially miss the spot, right? Because what you want to do is you want to get that spot, and those cells should look abnormal, and the question is whether they're cancerous or not. So so the rate of the false negatives is relatively high. I think at that point they send you back in for another procedure. The other thing they can do is not through bronchoscopy. They can do it through interventional radiology. So they get you set up in a lab that has intraoperative CT, and they can essentially guide a needle right into the spot, and they confirm that they're in the spot before they take the sample. It is. The problem is that the rate of getting a deflated lung is a couple percent, like 5% or something like that. So because you're puncturing the pleura, and you pull it out, and you might lose lung pressure. So that's why it's not ideal. I mean, lung cancer is so deadly. In fact, when I was walking over here, I noticed at your bus stop, there's a big sign that says, "You quit smoking, now get screened." It's very deadly. So it seems like getting screened. The CT part is easy, right? And if you come out, that's just a scan. And if you come out negative on that, then you got nothing to worry about. So I don't know. I don't know if I've thought about that deeply enough, but it seems like getting screened is the right thing to do. So how this might eventually look in a controller would be you would have a robot. It would take a picture. That picture would come back and go into this trained neural net. And again, what it would do is it would give you this registration between the two images. You would take that delta, add it to where you were at your last time point, and then essentially feed it in your motion controller, and then it would iteratively update. So it's a pretty simple structure we're proposing. And again, no surprise that if you do this in simulation, where this is a simulated virtual image and a simulated real camera image, they look pretty similar. They stay very well aligned as you move down the lung. Of course, this will be a lot more challenging when we get to the real images, as we're just starting to. Yes, so this handles the motion nicely. So let's see, I want to acknowledge the key people that are working on this. Michael Yip, who did the modelless control, Jake, who did the kind of hybrid with the rotation as well as estimation, David Eng, who's now working on this neural net, and our clinical collaborator, Ryan Van Wert. Thank you very much.